introduce us. Okay, so good morning, good evening, wherever you are in the world. My name's Jenny Fitzharding, and I am one of the volunteers for NEA BPD, the National Education Alliance for Borderline Personality Disorder. For those of you that aren't, first up, I just want to acknowledge country that, and in the spirit of reconciliation, NEA BPD acknowledges traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today, especially those that may have made it for today's webinar. I'm on Whadjuk Noongar country, and yeah, just respecting everyone across Australia. So NEA BPD, for those of you who may not be familiar with the National Education Alliance for BPD, this is an organisation that started in the US and we're the Australian branch of it. And we primarily aim to support families and carers of people living with a personality disorder, which can affect up to 17% of the population. NEA BPD is volunteer run. We have more than 200 active volunteers right across Australia, and we're one of 26 countries around the world that offers the Family Connections program, which is a program for families and carers of somebody with BPD. It's a 12-week evidence-based program that offers skills and hope to family members and carers. It's completely free, and it is led by our volunteer leaders who generously give their time to support other families. We receive no government funding and rely solely on the generosity of our families and supporters. So first up, I want to thank our presenter, Dr. Brad Reich, for so generously giving his time, and to anybody that was able to donate as a result of this webinar being available. So what is today about? Today is waves and walls, navigating the difference between bipolar disorder and borderline personality disorder. Mood instability is a hallmark of both bipolar and borderline personality disorder, but the underlying causes, patterns, and treatments are distinctly different. This webinar will help you navigate the diagnostic overlap and clarify key differences, whether you're a clinician, carer, or someone with lived experience. And we're very lucky to have such an experienced researcher and practitioner presenting for us today. Brad Reich has been an attending psychiatrist at Maclean Hospital since 1990 and working as an inpatient attending doctor from 1990 to 2007. He had positions in the psychotic disorders and dissociative disorders and trauma programs. Between 2010 and 2012, he served as an attending psychiatrist at the Gunderson Residence. He was previously the assistant medical director of the Pavilion. Dr. Reich has also been attending psychiatrist at the Obsessive Compulsive Disorder Institute and in the prolonged exposure track of the 3 East Partial Hospital Program. Since 1992, Dr. Reich has been involved in research relating to borderline personality disorder and bipolar disorder. He has published studies on the pharmacotherapy of PTSD and affective instability in borderline personality disorder. He's currently engaged in a study of the neural correlates of affective instability in borderline personality disorder and bipolar II disorder. So just before I hand over to Dr. Reich, for those of you that have submitted questions, we'll be having a short Q&A at the end of the presentation, and you can also add questions into the chat, and we'll try and get through as many as possible. And we'll also put a donation link in the chat for anyone who would like the opportunity to help us. Okay, please keep yourself muted during the presentation, and we will also be recording this webinar, so please turn off your camera if you would prefer not to be displayed. Okay, so I'm very happy to now hand over to Dr. Reich.
All right, well, thank you for the introduction, and looking forward to talking about something which I've been studying for a long time now. And this presentation, I'll try to keep it as non-technical as possible, but being an academic, There will be some slides which look pretty technical. I will just try to highlight what I think is clinically relevant there. And if people want to, why don't we save questions until the end? I have a list of the questions that were sent me. Hopefully some of those will be addressed in this presentation. So, all right, let's get started. Trying to move this slide forward. And the question is how I do that.
If you just hit your next cursor, that should take it through.
No, it's not doing it. Hold on. Here we go. There we go. All right. So let me start with a case, just to sort of set this up, and of how that illustrates, I think, pretty well the misdiagnosis of bipolar disorder in patients who are borderline. So this is a 39-year-old woman I treated for a number of years. She came to me having received a diagnosis of bipolar disorder. She was on a combination of mood stabilizers. And when she came to see me, she was very angry and irritable at her current psychiatrist because she believed that person had mistreated her. I was asked to consult, ultimately wound up being her attending psychiatrist for a number of years. She was on a medication called Abilify, that is aripiprazole, which is an antipsychotic and mood stabilizer. And actually, it helped her significantly, but she didn't like it because she had gained some weight on it. So we took her off it, and she got much more irritable and much more rageful. I convinced her to go back on it, and she was much less reactive, but she continued to have a lot of difficulty managing her anger in intimate relationships, particularly with her husband. And 4 years after beginning the work with me, her husband became severely depressed, and they subsequently decided to separate. The patient initially became less irritable after making this decision, but found she just couldn't tolerate the separation. And they, for some time, continued to have some kind of relationship, but it was one in which she could regulate the distance between them pretty much as she wanted to. Kicked him out of the house numerous times, but always brought him back. So this is someone who, there was nothing bipolar about her. She had never had what I consider to be a manic episode. She had these rapid mood swings, which were always very reactive. She struggled with anger and irritability. She never had what I consider to be a major depressive or a bipolar depressive episode, although she claimed to have had one. So this was pretty classic. And I had wound up trying her on other mood stabilizers over the years. Nothing seemed to work as Abilify, as well as Abilify did. But ultimately, we stopped working with each other because she wouldn't accept the fact that she really was borderline. All right, so what's the relationship between these two disorders? Are they the same or discrete syndromes? Do they have similar causes? How can you differentiate them? And what do people who have both look like? Because there are a fair number of people who do have both. So why is this important? Well, the main reason is because clinicians frequently misdiagnose BPD as being bipolar disorder. And that means that they focus too heavily on pharmacotherapy and not often enough on psychotherapy, which is really still the treatment of choice for most patients who are borderline. And in fact, one study which was done by my colleague Mark Zimmerman here in the United States in 2010 found that actually 24 of the patients who came into his program, which is a partial hospital program in Massachusetts, were misdiagnosed with bipolar disorder when they did a structured interview that diagnosed patients fairly rigorously. So here are the symptoms of the two disorders, right? You wouldn't necessarily think that they would overlap. I'm not going to run through all of them, but I think what causes diagnostic confusion is because of what's highlighted in yellow. Irritability, depression in bipolar disorder, and impulsivity. In borderline personality disorder, more general impulsivity, anger, and unstable reactive mood. And I think it's those particular problems which often confuse clinicians when they're trying to separate one from the other. I also want to highlight that there are actually several kinds of bipolar disorder, but in terms of this presentation, I want to highlight the difference between bipolar 1 and bipolar 2 disorder. And the main difference is that the manic symptoms in bipolar 1 are much more severe than in bipolar 2. And they may last longer, although not necessarily. They result in some serious impairment in functioning, like having to miss work or lose a job. They may result during a manic episode in a patient being psychotic with delusions or hallucinations, and they also may result in hospitalization. People who are bipolar 2 do not have such severe impairments when they're manic. They may have very severe impairments when they're depressed. And in many cases, depression is a more predominant mood disorder in the bipolar 2s than the bipolar 1s. Okay. The other point to make is that bipolar 2 symptoms occur more frequently in women and are more closely associated with BPD. And actually, my work looking at the two disorders, that is bipolar disorder and borderline personality disorder, is focused on studying bipolar 2 patients, not really bipolar 1s. All right, so the other thing that I think can result in diagnostic confusion is so-called mixed state, also known as dysphoric mania. When you have a lot of the symptoms of mania, not sleeping, having racing thoughts, being impulsive, having a lot of energy, being very driven, without the euphoria. In fact, you may feel depressed, but have a lot of manic symptoms. And I think there are many clinicians out there who would be inclined to see a lot of the dysphoric states you see in anxious, agitated, borderline patients as being mixed states, although I think the two are actually pretty clearly differentiable. So I also want to highlight this concept of state versus trait, because that really is a lot of what separates the two disorders. Bipolar disorder is more likely to involve separate emotional states that actually that don't change much over long periods. Whereas BPD is more likely to involve chronic difficulties, which may get better or worse depending on one's stress level. And so I would argue that although bipolar patients are not normal when they're well, that is, not depressed or manic, they're a lot closer to being normal than borderline patients for whom have disorders both state and trait, which means that they have these chronic problems which may be exacerbated by stress and put them into a state, that is, where they're much more symptomatic. But it's not like they're borderline 6 months a year. It's not like they have seasonal variations in mood. So what I'm going to argue in this talk tonight is that BPD is more of a trait disorder and bipolar disorder is more of a state disorder. So what's the evidence supporting a connection between the two disorders? Well, there is in fact a higher prevalence of bipolar disorder in BPD than in the general population. Mood stabilizing drugs may improve the emotional symptoms in BPD, as well as bipolar disorder. I think they're generally more effective in bipolar disorder than in BPD. And last of all, that individuals who are so-called rapid cycling bipolar patients, that is, have frequent mood changes, and let's just say mood changes more than once a week, are more likely to have characteristics of BPD. So if you look at populations of borderline patients and bipolar patients, you find that in each, there's about 20% of the other disorder. So that's a pretty high number. But that also means that 80% of the patients with each disorder don't have the other. And this slide just simply shows that if you follow borderline patients over time, you see more frequent onsets of bipolar disorder than you would in the general population or in patients with other psychiatric disorders. So again, there's some suggestion there's a link, although I actually don't think it's that strong a link. And as far as rapid switching goes, well, if you look at rapid cyclers, you see that they have my impression is the more rapid cycling someone is, that is, the more frequently they have mood shifts that aren't necessarily even borderline mood shifts, which may involve euphoria or depression and are not triggered by stress or other people's behavior toward them. You see that the more mood swings they have, the more they look borderline. They have more comorbidity, eating disorders, other psychiatric problems, anxiety, substance abuse. They have more suicide attempts, and they also have an earlier age of onset, which would be more typical of borderline personality disorder. And then this just shows that these 4 mood stabilizers, there are probably some others, seem to be effective in both disorders, although, as I said, they're more effective, in my opinion, in bipolar disorder than in borderline personality disorder. Now, there's also a lot of evidence that the 2 disorders are not the same. One piece of this is that, in fact, bipolar disorder is not the most common comorbid disorder in BPD. I believe it's an anxiety disorder or maybe substance abuse, but it's not necessarily bipolar disorder. Also, that BPD does not occur more commonly than other personality disorders in bipolar disorder. There's no clear evidence that bipolar disorder is more prevalent in the families of patients with BPD. And then last of all, those who believe that disorders are actually different would say that the affective instability in BPD and bipolar disorder are defined differently, with the definition of BPD, affective instability, and the DSM-5 emphasizing emotional reactivity. And we'll talk more about that later. So these are the 2 symptom categories where I think people think there's a link between the 2 disorders, and those are what we're going to focus on tonight, both impulsivity and emotional mood symptoms. So I'm not going to get into this study in detail. It's a small study of impulsivity using this instrument called the UPS questionnaire. And this creates 4 different subscales, but what's most important here is that in yellow, this research found that the tendency to act impulsively when experiencing negative emotion was more likely to occur in borderline patients. So bipolar patients, they may act impulsively, particularly when they're manic. But the profiles of the impulsivity are different. Borderline patients are more likely to engage in promiscuity when they're feeling bad, or they may break things. They may drive recklessly. But this is usually a response to distress. It's not a response to feeling revved up and manic. So the other thing about this study is it showed that compared to people who have no psychiatric diagnosis, bipolar subjects in the study had higher levels of this problem of acting when impulsively when they were experiencing negative emotions. It just was not as clearly pronounced as that of borderline patients. So these are some clinical observations I've made over the years with respect to the 2 disorders. Both disorders may involve difficulties with impulse control. Both may involve multiple forms of impulsivity, which is less state-dependent in BPD than impulsivity in bipolar disorder. So in BPD, impulsivity is more of a trait. Again, in bipolar disorder, it's more of a state problem associated with manic or mixed states. The last point is there's a small group of people who who self-injure when they're in a mixed state. These are bipolar patients who cut themselves, do other things to injure themselves. It's mostly self-cutting, but they're not borderline. And if you talk to them about their behavior when they're not in a mixed state, they'll tell you, no, in fact, I have no urges to injure myself. And these patients will talk about a sort of internal drive, if you will, like the motor just won't stop running. that forces them to do this and behave in ways which are manic. Borderline patients will not describe that. All right, so what about emotional symptoms? I'm going to talk about 5 different categories here: anxiety, anger, depression, affective instability, and finally, emotion regulation or dysregulation. So this is a study that we did as part of an MRI study we did a number of years ago, measuring anxiety in type 2 bipolars and borderlines. And you can see from this that the borderline patients reported more chronic anxiety than bipolar patients. Borderline patients are very anxious people. Some bipolar patients are. I think they have elevated rates of anxiety compared to the general population, but it's not on the same level as patients with BPD. This study, a much larger study, showed that borderline patients may have more severe depressed states and higher levels of anger than patients with bipolar disorder. So I think, again, someone who's in a manic state, they may be pretty irritable and angry, but that's state dependent. Whereas borderline patients, yes, they may be more prone to anger if they're upset about something, but it's more of a general sort of trait problem. Now, what about emotional instability? Well, DSM-5 defines the instability differently in BPD and bipolar disorder, but the definitions do have some overlapping features. Here I've highlighted some of the key features for affective instability in BPD: dysphoria, irritability, anxiety, anger, panic, despair. This definition emphasizes emotional reactivity as opposed to more endogenous, that is sort of self-generated mood states that don't really seem to depend on the environment as much. And this is the DSM-5 definition of a manic state, which again mentions dysphoria and irritability. And this is the DSM-5 definition of a mixed state, which we'll talk about anger and depression, all mood states which can occur in BPD. And the way it defines it here, it says that you may have some of these mixed emotional features for short periods of time, and there may be a lot of fluctuation. I've observed that in bipolars. I just don't think that their mood states most of the time are as complex as those of patients with BPD. All right, so I'm going to skip over these slides, but basically what I'm going to do is to talk about 2 features of affective instability. The first is how rapidly mood changes, and also the intensity of the mood that occurs when there is a mood shift. It's a study we did a number of years ago. Again, I'm not really going to talk about the specifics of this, but what I did was I put together a questionnaire that enabled me to create subscales of different kinds of mood swings. And I thought that some, like the ones on the left, were more typical of bipolar patients, those involving depression, elation and depression. And there were some that were more typical of borderline patients, those that involved anger, anxiety, shifts between depression and anxiety, between anxiety and depression.
Brad, can I just double check my
Yes.
understanding of the definition of euthymia? That's just a general state of
It's
well-being.
just like feeling okay. Sorry, it's a
Right.
technical feeling okay. So good to go from feeling okay to angry, or okay to feeling anxious, or okay to feeling elated, or okay to feeling depressed. So thank you for clarifying that. So I was able to construct these different subscales that I used, I put together after assessing patients with my instrument. And so this is what I found. Okay, actually, this is what I found was that bipolar subjects reported more frequent shifts between feeling okay and being elated, whereas borderline patients reported more frequent shifts between depression, anxiety, between anxiety and depression, and between feeling okay and being angry. And so how does one interpret this? Well, again, I think if you look at the profile of someone's mood states, um, BPD subjects tend more frequently to shift into angry mood states and to mood states involving depression and anxiety. Where the other piece of this study was that we found that when we looked at intensity of mood, the bipolar 2 patients reported more stronger positive emotions than BPD patients. And I think this is an important point because one of the things that borderline patients really struggle with is that they don't have as positive emotions the way many of us do. And in fact, much of the treatment for bipolar disorder might actually involve helping borderline patients experience more positive emotions. Now, this is a study that I included because it's a self-report study that's done longitudinally. So it involved 48 participants with bipolar disorder, 31 with borderline personality disorder, and 51 healthy comparison controls. And they asked subjects to rate their mood daily for a year. And they got a median response rate of 313 days, pretty good. And in this study, they looked at different types of moods: anger, sadness, irritability, anxiety, and elation. They asked patients to rate each one of these emotions on a 7-point scale. And then they divided the results into 3 overall groups: one with negative emotions, one with positive emotions, and then irritability. Why they separated irritability from negative emotions, I don't know, but they did that. And what they found was that BPD patients had higher general scores on negative emotions and irritability than bipolar patients. And that they also reported greater daily variability in their mood than bipolar patients on negative affect, positive affect, and irritability. So what I think you need to take away from this study is that borderline individuals have more negative emotions than bipolar individuals. That's consistent with my study that I just talked about, which showed sort of the other way around, which is that bipolar patients had more positive emotions or more intense positive emotions. But borderline individuals have more negative emotions, and also that their emotions are just more unstable. I mean, if you were to look at a plot of the emotions of a borderline patient over a period of time, you would see that the ratings would be much more random and all over the place than they would be for most bipolar individuals. Now, I'm going to talk for a minute about a study that I did, which involved ecological momentary assessment. That is, asking patients to rate their moods 3 times a day for a week on a Palm Pilot. So this is a pretty old study. No one uses Palm Pilots anymore. And I asked about the different types of mood swings that I mentioned before. And then analyzed the data using basically the same scheme to separate out the different types of mood swings that I used in a previous study. You can see it looks pretty similar. I added shifts between anxiety and anger and between feeling okay and being ashamed. But the other mood changes were the same. And so the specifics of these slides are less important than just sort of the gestalt. But if you look at these so-called more bipolar type mood swings, there was no separation between the 2 groups, no significant difference. But if you look at the more borderline mood swings, you can see that there are a number of differences. And in all these cases, the borderline patients or subjects reported a lot more frequent mood shifts than the bipolar patients. So again, there's clearly sort of a different overall profile of mood instability. Again, looking at intensity of mood, when the mood into which one shifted, no differences with respect to more bipolar mood swings. And the only difference we found with respect to intensity in the borderline mood swings was with respect to anxiety. And that makes sense. I mean, again, I think borderlines are more anxious than bipolars. So it makes sense that the intensity of their anxiety would be greater. Now, and then this just slide shows that if you construct a scale looking at the frequency of bipolar mood swings, you can differentiate pretty clearly between the two groups. If you look at those numbers, 39 versus 11.8, that's a pretty big difference. So in general, if someone will report accurately, I could give them my instrument, and based on the score of that, could probably tell you whether they were bipolar or borderline or both. But here's one of the reasons I mentioned this study. One of the things that we did in this was to ask every time we queried someone about a mood change or a series of mood changes, we asked, did something stressful or unpleasant happen to you in the last period during which you're rating your mood? And you can see that the two groups, it's about the same. First of all, it shocked me that borderlines only reported a mood shift connected to some sort of stressful or unpleasant event about a third of the time. I figured it would be closer to 80 or 90%. But it was also shocking that the bipolars reported about the same frequency of this. So how does one interpret these results? Well, it may be that the mood instability in the two disorders are not as reactive, or in borderlines are not as reactive as we thought. Could be, but an equally plausible interpretation is simply that the borderlines didn't recognize stressful events that might have triggered their affective instability. So what I would take away from this is that it may be that even though I think borderline mood instability is much more reactive to interpersonal stressors on a day-to-day, hour-to-hour, minute-to-minute basis, it may be that some of the shifts are kind of random, because I've certainly seen borderline patients who said to me, I just woke up this morning and I felt different. Nothing particularly happened, or I did experience a shift in the middle of the day. But in my experience, it just does not happen as often as it happens in bipolar patients. All right, so let me talk for a couple of minutes about emotion regulation in the two disorders. This was a study that may have come out of Australia, actually, using an instrument called the DIRS, the Difficulty in Emotion Regulation Scale. And this just talks about the different types of emotion regulations that are assessed with this. One is assessing emotion regulation strategies. Another is clarity of emotions. Other is overall emotional awareness. Another is problems with controlling impulses. And there's catastrophizing and then blaming oneself. And what this study found was that borderline patients had significantly more difficulty in those categories, in multiple dimensions. So just in general, I would say that for individuals not in a manic or bipolar depressed state, they are able to regulate their emotions much more easily than borderline individuals. On the other hand, I would say that probably their emotion regulation capacity with respect to these would be impaired relative to healthy comparison subjects who did not have a psychiatric disorder. So again, the point is, I think bipolars, even when they're not manic or depressed, may not be normal, but they don't necessarily look like borderline individuals. So are there any measurable biological differences between the two disorders? I did a study which yielded a pretty general but positive result, a very small study, about 30 individuals. And what we found is that if you look at brain connections, the bipolar 2 subjects had increased connectivity in their brains between the right amygdala and different brain regions. It's very nonspecific because the other brain regions that they were connected to, the right amygdala was connected to, were not necessarily ones which were involved in emotion regulation or anything like that. But there was certainly a difference between connectivity between the amygdala, which is one of the seeds or seats of emotion in the brain, and parts of the frontal or prefrontal cortex. And these differences survived even when you corrected for things like emotional instability, impulsivity, or anxiety. Um, so that's pretty clear evidence, in my opinion, that there's a biological difference between two disorders. I don't think we really understand what that is yet. This is just a pictorial illustration of the differences. You can see that the red bars show how much stronger the connectivity was for the bipolars than the borderlines. All right,
Sorry,
so
Brad,
let's
just
talk.
for the non-technical people in the room,
Yes.
what does that mean? If you don't have a strong connectivity to your amygdala, does that just mean you have less chance of controlling your emotions?
Yeah, I
Or
mean, it just means you can't recruit those parts of the brain that are involved in emotional control as effectively as someone who's bipolar.
right.
Does that make sense? I mean, there's
Yeah.
certain parts of the
And
brain that are thought to be crucial for regulating emotion, other parts that are thought crucial in generating emotion. Now, I'm oversimplifying when I say that, but the amygdala seems to be one of the places that are key for generating emotions. And there are places, the amygdala is sort of kind of pretty deep in the brain, and there are parts of the brain that are more on the surface that are more uh, evolutionarily new, shall we say, they're evolutionarily modern, that are used, we all use to regulate our emotions. And the connection between those two areas is, in my opinion, much weaker in borderline patients than in the average person, and also compared to bipolar patients. And by the way, the patients in the study, the bipolars, that is, they were not in a depressed state. They were not in a manic state. We asked them to come in at a time when they were not particularly symptomatic, just to look at the so-called underlying architecture of their brains, independent of the actual mood state. So
great.
does that clarify
Yeah,
what you're
yeah, it does. And sorry, I know that we were going to put the questions at the end, but just while we're on this topic, has anybody ever done a study looking at um, somebody with BPD who's successfully been treated? You know, like we do have people that go into remission. Um,
Yeah, I
and
mean, I think
does
that
that then show up that there is connectivity? Because we know the brain is plastic. We know the brain can change. Um,
that's a good question. I can't say that I am really as current on the literature as I would like to be. I can tell you that in general, um, you know, that people who, if you look at the brains of people who get better, borderlines who get better, I think you do find that there are some changes. But what my reading of the literature when I published this was that there was really tremendous variation. What you did see was that borderlines had amygdalas which are more reactive, if you will, that they tended to light up on functional MRI studies, um, brighter than those of control subjects. But I don't think that there's a lot out there on sort of functional connectivity, which is like this was just done in a resting state. And so I'm not sure there's much of a literature out there on this. But my guess is, yes, it would change.
yeah,
So I'm sorry I can't
thank
answer
you.
that definitively.
No, that's great. It's really
Uh,
interesting. Thank you.
all right. So the question is, uh, might childhood adversity or temperament differentiate the two groups? Because for a long time, it was really thought that BPD was a result of childhood abuse, childhood adversity. And even now, I think people would say, in general, there's some people who would say that there's much more trauma in the childhoods of borderline individuals than there is in the childhoods of normal individuals or perhaps individuals with other psychiatric disorders. So we did a study. Um, this is actually the first part of a study that I'm just now finishing up, looking at the longitudinal course of the two disorders. And about 100 people, and we assessed them using, I'm not going to get into details here, we assessed them using the childhood trauma questionnaire, which just asks about childhood trauma. It's an instrument that's been around for a long time, considered one of the gold standards. And also this instrument called the NEO, which looks at temperament and assesses temperament in terms of 5 underlying subcategories. And I would say that that instrument really it assesses kind of the underlying biological architecture of personality, if you will. And so could be looked at as an indication of sort of what one had been born with, if you will, in terms of temperament and personality, as opposed to what might have been shaped by childhood trauma. So this is these are the results with respect to the childhood trauma questionnaire. You can see there are really no differences between the two groups. What we did in this part of the study was to control for severity of illness. And when you control for severity, look at bipolars and borderlines on the same level of severity of symptoms, you find there are no differences. On the other hand, when you look at traits that have some heritability or that may be more inborn, you can see that borderlines do have some significantly increased scores with respect to neuroticism, which is just kind of a catch-all area for things like anxiety, impulsivity, depression, difficulty separating. And then also on agreeableness, which I think speaks for itself, with borderlines having higher levels of neuroticism and lower levels of agreeableness. So, my interpretations of this is that the two disorders differ primarily with respect to underlying temperament and genetic architecture, and that environmental factors have only a limited role in looking at the differences in causation in the two disorders. This is going to be controversial for a lot of people, but it's the position I've come to over the years that a lot of people with borderline personality they're just born that way. And that, yes, in some cases they may have had inadequate parenting, but I've certainly seen plenty of borderline patients who had really fine parents who were doing everything they could for them. And they were just dealing with someone who had a very difficult temperament. All right. And I should also say, by the way, that it looks as though childhood abuse is really a very non-specific risk factor. That if you look at across all psychiatric disorders, you see that there are elevated rates of childhood abuse and adversity. So it's not just specific to BPD or bipolar disorder or depression or substance abuse. It really is just a general factor. All right, so I'm going to end the body of the talk by talking about patients who have both BPD and bipolar disorder. And I thought I would just talk about sort of a made-up case here to illustrate this. So this patient was a 26-year-old female who reported a history of being emotionally sensitive since she was a young child. As a teenager, she had multiple unstable friendships and romantic relationships. She often drank to the point of blacking out. Whenever she felt mistreated or abandoned by friends, she cut herself on the thighs. She began to have episodes of depression in the fall and early winter. And then in the spring of her junior year in college, she presented to a local health service with increased energy, racing thoughts, pressured speech, not sleeping, and feeling more agitated. With the change in her mood, she said she had initially felt better, but as this developed, she reported now feeling she wanted to jump out of her skin. She said she felt there was a motor running uncontrollably inside her. Her agitation and overall mood improved when she was treated with lithium and an antipsychotic. But within several weeks, she began to have symptoms of clinical depression. Although these symptoms improved with changes in her pharmacotherapy, she continued to have seasonal mood changes over time. And although she reported becoming better able to manage relationships and urges to self-harm during her 20s, she continued to struggle with frequent moments of distress because of her interpersonal sensitivity. And after a difficult breakup, she made a serious suicide attempt by overdose. So you can see sort of two threads in this. The first one really is pretty classically borderline, someone who's interpersonally sensitive, who self-injures, who can't manage relationships. And then all of a sudden, she has a manic episode. And there was some clue this might, what she had might become bipolar when she talked about seasonal mood changes. And I would say that more often than not, if you're in a temperate climate where there are significant changes in sunlight, bipolar patients will tell you that they have seasonal changes in their mood. They're more depressed in the fall. They're more depressed as the days are getting shorter. They're in the Northern Hemisphere. Often their depression is the worst between Thanksgiving in America and Christmas. Their mood may become slightly better starting around New Year's. And then in the sunnier months, that is the months really beginning the end of March into April, May, and June, they're much more likely to feel energized, sometimes in a good way, sometimes in not such a good way. So again, it doesn't happen that way for all bipolar patients, but that's one of the first things you want to ask in trying to diagnose whether someone might have bipolar disorder is, do you have seasonal mood swings? So, what's it, what's the overall profile of these patients who have both? And the answer is that they're sicker. They have a study by Zimmerman and colleagues found they have more depressive episodes. They have more childhood trauma. They have more suicide attempts, and they have just more difficulty functioning, more chronic unemployment. So, you really have to attend to both the borderline piece and the bipolar piece. Look, there's certainly some patients with both who do fine, but in general, it's a much more complicated clinical picture to manage. So, what can we conclude here? I would say that BPD and bipolar disorder may have overlapping causes, but it's still not clear really what the differences are. It does appear that there's significant biological differences, that they have different profiles of impulsivity. BPD patients are more likely to act impulsively in reaction to negative emotion, almost as a way of making themselves feel better. Borderline patients often report higher levels of hostility. They have higher overall levels of anxiety than bipolar patients. Their emotional instability appears much more complex, with more shifts than bipolar patients in multiple dimensions involving anxiety, anger, and shifts between depression and anxiety. The intensity of the negative emotions or positive emotions may or may not differentiate the two groups, with the possible exception of shifts between feeling okay and feeling anxious. But some people would say, well, borderline patients are chronically anxious, so they don't really shift into more anxious states. I don't think that's completely true. Borderline and bipolar patients may have similar proportions of reactive mood shifts, although maybe not. I think the jury's still out on that one. I would say my clinical experience is still that borderline patients are more reactive, but looking for more research evidence of that. I think BPD patients have more general difficulty regulating their emotions. Certainly bipolar patients have difficulty regulating their emotions when they're manic or depressed. But when they're in between those states, I think they're probably better at regulating their emotions. As I said earlier, the mood instability and impulsivity in BPD are more trait-like, that is constant, than in bipolar disorder. Although, look, borderline patients do become more unstable mood-wise and more impulsive when they're under stress or feeling anxiety. So in that respect, it is both a state and a trait disorder, which, unlike bipolar disorder, which is really more clearly just a state disorder. And BPD is more a disorder of interpersonal hyperreactivity. So one of the questions you would ask someone if they talk about having a lot of mood swings and you want to know whether they might be borderline is, are you a really sensitive person who reacts strongly to input from other people? That's one of the questions I always lead with. I would say that in some respects, the diagnosis of BPD is much easier to make than the diagnosis of bipolar disorder, because to really make the diagnosis of bipolar disorder, you may need more longitudinal long-term information. I've seen a number of patients who are bipolar who had me fooled. They looked fine for a number of years, and then all of a sudden they had a manic episode or an episode of bipolar depression, and which made me realize that, someone can look pretty good for a long period of time if they're bipolar and then become more unstable. The other thing is there are a lot of borderline patients who really don't want to be borderline and would much rather be bipolar. And so what they do is they create a story about themselves, which makes them look more bipolar. And that can make it difficult to diagnose someone until you get to know them better. So that's something I watch for whenever I'm treating someone who doesn't look particularly bipolar, but is really trying to convince me that they are. And bipolar patients typically, although not always, will report some period of elevated mood, some period where they felt kind of euphoric, and may be very fleeting. But that may occur in BPD, but it's much less common. As I said a couple of minutes ago, there's a significant number of patients who have both BPD and bipolar disorder. And the evidence suggests that they are more symptomatic and function worse than patients with one or the other disorder alone. And then last of all, I think if you're trying to distinguish the two disorders based on a history of child adversity, that's probably not going to lead to an accurate diagnosis because you'll diagnose a lot of bipolars as being borderline just because they have childhood adversity, when in fact, the two groups really have similar levels, and that it's really temperamental factors that are largely genetic that may separate the two. So that's pretty much all I have to say. I'm glad to answer questions. I mean, I had this list of questions that I was given. If you want me to run through those, I can do that. I can just take questions from, the audience.
I mean, I guess this is absolutely fascinating. Brad, thank you so much. And I am wondering though, obviously it's really important to get this diagnosis right, because in what ways do the treatments differ? Like if someone is mistakenly diagnosed with borderline, with bipolar, and they're not, are there harms from the medication or the other way around, or do you find that you're using mood stabilizers for both?
So here's what I would say. If you mistakenly diagnose someone as bipolar and they're borderline, you're probably going to medicate them in ways that may not be so effective. They might be somewhat effective. I mean, that first patient that I presented, she really benefited from being on aripiprazole, which is a mood stabilizer used in bipolar disorder. I've got to say, she was the exception. Most of the bipolar patients or borderline patients, rather, that I see, they don't benefit from the mood stabilizers to the same degree. So you often see a lot of borderline patients with a lot of bipolar or mood stabilizing medications layered one on top of the other. And that carries with it the problem of weight gain and metabolic dysfunction. So a lot of these patients, will put on weight when they may not, they may have been put through something they didn't need, and the result is a side effect, which can be very unhealthy. The other thing is that if you misdiagnose someone as bipolar, they may be looking for the medication cure and not be willing to pay attention to building skills, to doing a piece of therapy, which might be helpful. And so reframing it as borderline actually, I think, gives them an understanding that's going to be much more helpful than just saying, well, we just haven't found the right medications for you yet. Is that clear?
Yeah, that helps. And I might just get you to stop sharing your
oh, sure. I'm glad to
slides so that people can see you. I'm not sure. Sorry. So I might just go with some questions that we've actually got from people that are here.
Okay.
So that's asking, her daughter has just had her diagnosis changed from borderline personality disorder to bipolar due to significant sleep disturbance. Is that something that's part of your study, or something that you notice as a difference?
Well, again, I think you can get sleep disturbance in both disorders. My experience is that borderline patients often have sleep difficulties, whereas bipolar patients, they might. I mean, particularly when they're manic, they're not going to be sleeping. And if they're really depressed, they might not be sleeping much. But I think the typical bipolar patient, when depressed, will be sleeping a lot. So, I certainly would not at all be inclined to make the diagnosis based on sleep disturbance. I think that's a very non-specific indicator.
Mm-hmm. Okay. Um, sorry, we sort of got a question about ADHD and autism and CPTSD, but I think that, as you said, that might be a whole other webinar
Yeah, I
topic.
mean, I think that the short answer is that complex PTSD and BPD are not the same, in my opinion, but that is a talk in itself, the relationship between trauma and borderline personality disorder.
Yeah,
I mean, I alluded to it a little bit at the end of the talk, but it's complex.
yeah. Um, and just a technical question: is borderline bipolar 2 cyclothymia or a cyclothymia? Cyclothymia is just a word that describes mood changing rapidly, right? Is that
Yeah, rapid mood swings, yes, exactly.
yeah? So rapid mood swings can be happening for a variety of reasons,
Yeah, I
other
mean,
than
and
bipolar.
I treat a number of bipolar patients, but I don't work in like a bipolar clinic. So I haven't seen a lot of people I thought were cyclothymic over the years. I am sure they are out there. Um, but those people, they might look pretty borderline. If you're having mood changes, several times a week that just seem to come out of the blue, uh, how do you build a healthy personality disorder if your life is that unstable?
Mm.
And that's what I was saying earlier in the talk. The rapid cycling correlates with more borderline features.
Yeah, yeah. Um, this is an interesting question. Are there any studies looking into how changes in emotional literacy impact symptoms of borderline, bipolar disorder, or both?
Well, I think psychoeducation is very important for both disorders. There was a time when people were scared of giving someone a diagnosis of borderline personality disorder and educating them about it. Now it's done very commonly.
Mm.
So I think the more borderline patients can be attuned to their mood states and their emotional changes, the better. It will improve their emotion regulation tools. My experience with bipolars is that, particularly when it comes to shifting into manic states, you know, you can give them plenty of education, but once they're manic, it seems like their insight flies out the window.
Mm.
And I have a few patients. I have one patient who actually has been diagnosed with both, and she's had several manic episodes. The last one of which was so bad, actually, that her husband decided to divorce her. Uh, and she has young kids, so it's really quite tragic. But I've just accepted the fact she didn't think she was manic when she was manic, and she just didn't recognize it, and that she probably never will. And so I'll have to rely on family members or people around her uh, to uh, to alert me that she's manic and that I need to make some medication changes.
Mhm.
But look,
Yeah.
I still think that there are whole um, I think there are whole modules that try to teach bipolar patients, how to identify their mood shifts more. But I think borderlines tend to get it more quickly.
Yeah. That sort of relates back to, that slide where you were surprised that the numbers were the same with people with BPD and people with bipolar, around not being able to identify what shifted the mood.
Yeah, potentially,
And
right.
yeah, my experience, and that sort of feeds into that alexithymia, the not knowing
Right.
the emotions, because my experience of working with clients is they go, oh, it came out of nowhere. And I'll go, did it? Let's have a look at that. And when you
Right.
tease it
Yes.
all out, it might have been that they were ruminating on something, or that they had thoughts,
Right.
or something. That
Exactly.
nearly is always a cause. It's just the blindness to the cause and the blindness to their emotional experience that is creating problems for them.
I couldn't agree with you more.
Yeah. Okay. So I've got a question about medication. So is BPD more likely to be treated with antidepressants and bipolar more likely with mood stabilizers?
Again, a complicated question. I think there's some people out there who would say you should never treat a bipolar patient with an antidepressant. I'm not one of them. They would say that you should use mood stabilizers alone. I think that a lot of borderlines do get put on antidepressants. I'm not sure how helpful they are unless they also have clinical depression, and there are some borderlines who do have clinical major depression. I think both groups, at least here in the States, are treated pretty heavily with mood stabilizers. Again, I'm not sure how effective the mood stabilizers are for the borderlines. For a few, definitely. But I think you need to keep your expectations much more modest when it comes to using mood stabilizers in BPD, whereas they're essential in treating bipolar disorder. I mean, hospitals were full of bipolar patients chronically for years before we developed effective pharmacotherapies. There's no pharmacotherapy out there which has reduced the rate of hospitalization for borderline patients. Psychotherapy, maybe, but not medication.
Yeah. So yeah, and that psychotherapy, the studies now are looking more at not just psychotherapy, but what's really effective is looking at the whole of life stuff, isn't it? Like that.
Oh yeah, absolutely.
Yeah. Okay, so the questions that we had. Oh, sorry, we do have a question here about how do you treat sleep disturbances with people with BPD?
Well, I think the main difference might be that you want to be careful about using medications that might be addictive. So like benzodiazepines, I'm more cautious about using those with a borderline patient than with someone who doesn't have BPD and there's no family history of substance abuse. Um, so yeah, I mean that's really the biggest difference. But they could put on, again, sleep disturbance is a very generic thing and is transdiagnostic. So I mean, you see the same medications being used sort of regardless of diagnosis.
Yep.
If someone's manic and not sleeping, you want to treat the manic episode, and you may treat them their sleep disturbance at the same time. But it's the underlying problem is mania, not the sleep disorder. So I'm sorry. Go ahead.
Yeah. So, and there was a couple of questions around personality disorders. I think here, at least, there's a tendency now to not use the label borderline, just to talk about personality disorder generically and it being mild or moderate or severe, which kind of also feeds into another question too about, how often do you get comorbid BPD and narcissistic personality disorder? I mean, I guess I'm sort of mushing those two questions together because there's this whole thing around personality disorders and how we classify them, how we look at them, how we treat them.
Yeah, again, that's the probably hottest area of controversy in the field. Do you do categorical diagnoses? Do you do more dimensional diagnoses? I fall on both sides of the coin. I think it is useful to give someone a BPD diagnosis, at least in my experience, because it gives you some kind of framework to work within. But once you've made the diagnosis, you really need to focus on particular symptoms, which may vary from one person to the next. I mean, like all psychiatric illnesses, BPD is a very heterogeneous entity. One person's borderline will not be another's. A lot of people who have BPD outgrow it by the time they're in their mid-20s, whereas some really have this problem in a lifelong way.
Yeah, and do you find you have people have it coming on with menopause and things like that as well? Have you had much of that?
Yeah, I've seen very few late life onsets, relative in BPD. If what I would say is there may be a subgroup of people who have sensitivity and difficulty regulating their emotion, but for whatever reason, they managed to keep themselves in an environment which was fairly supportive. And if for some reason that environment got damaged or disrupted or taken away altogether, they could start to look a lot more unstable.
Mm.
You know, BPD across the life cycle in general, borderline patients look less borderline as they get older. Um, and you know, they learn how to regulate themselves better. I think for all of us, you know, your reactivity tends to decline as you get older. It's just natural. Emotional range may narrow as you get older. So, you know, borderlines tend to get better. What you see in bipolar disorder is more typically that you see fewer manic episodes and more depressive episodes. Um, Particularly, I think, I say particularly in women. I've had more experience with women than men with respect to bipolar disorder, but you just tend to expect a lot more depression. And then the transition into menopause for people with mood disorders can often be very, very difficult.
Mm.
You know, I've seen some people who became chronically depressed. I think there may be some people who had new onset bipolar symptoms, but it really needs to be paid close attention to. And again, this is not really the subject for this talk, but for women who are not at risk for something like breast cancer, I'm a big advocate of hormone replacement. Um,
Yeah. Yeah. Me too. It's, why not get the help if it's there? You know? Um,
so
so
there are all these questions in the chat. Are we addressing those?
I've asked you those questions.
Okay, all right.
Yeah. So don't worry about those. There's an incredibly complicated question that was sent in. I don't even understand it. I don't know if you do. In looking at the connections between BPD and bipolar, have you ever studied the effects of methylation of the glucocorticoid receptor gene in infancy? I don't even understand that. I'm sorry.
Well,
But if
I
you
know
can
what you're
explain
talking
the
about.
question, that'd be great.
I can't say that I have any expertise in that area. I don't know whether anyone has studied that. Um, if they haven't, they will.
Yes. Okay. Yeah. What did that question mean?
I mean, what I can say is that, you know, they've been trying to find the bipolar or, you know, borderline gene or genes for years. And the most they come up with is that, you know, there are many, many genes involved in each disorder.
Yeah. It seems like one of the questioners that was sent in, that they had the experience of someone taking a prescribed medication and then that person seeming to crave intoxication, you know, substance abuse, you know,
Oh,
using alcohol,
absolutely.
vaping, Valium. Yeah. So is that because it's a wrong diagnosis or the medicine's wrong, or, you know, what's the
I mean, some
story
people are
there?
just, you know, they're genetically wired for addiction.
Right.
And so, you know, you want to take a history, a family history, and find out, um, you know, are there family members with addiction problems? And as well as a history of the individual you're about to medicate and find out whether they've ever had any trouble with addiction. Um, but it's not really much different from the screening one would do if you were to prescribe pain medications for somebody. You know, there's some people who you give them an opioid like uh, OxyContin, and you know 3 doses and they're hooked just because of their underlying vulnerability genetically. And other people, you know, they'll take 5 pills and say, I don't ever want this medication again. So yes, you need to screen for the risk of substance abuse. And if you are going to treat someone with a potentially addictive substance, maybe not as a first line agent, but as a second line agent, you need to caution them about the risks, and you need, you know, to be careful about how many pills you give them
Yeah.
to start with
Okay.
anyway.
Um, I've got another question here about the comorbidity. You know, are you looking at BPD first, or are you looking at bipolar 2 first, or is it just a question of the person as they present in front of you?
Well, someone usually presents to you with some kind of chief complaint. Um, you know, you screen for both. You ask someone, are you a really sensitive person? Do you have a lot of mood swings? What's the nature of those mood swings? if there's no euphoria involved, and it seems like most of those mood swings are reactive, then you're thinking, well, this is something that's in the borderline range. But you still ask if you ever had what you consider to be a manic episode. There are times when you feel really elevated and up, and then your mood rapidly goes down. As I said, it's much easier to diagnose BPD than it is to diagnose bipolar disorder for many people, because unless you see someone in a particular mood state, um, and they're bipolar, you may not know that they're actually bipolar. So
Yeah.
people can go for years without having a manic episode or even a major depressive episode.
Yeah, that's sort of, one of those things that you do look at, isn't it? Do you have long periods of functioning normally,
Yeah.
and like, is that sort of key differential diagnostic tool the interpersonal relationships? Is that one
Yeah.
of the things that says this is BPD because this person really struggles with attachment and reacting to how other people
Yeah.
treat them?
Exactly. Usually in an interview with someone, if they can be honest with me, um, they'll tell me that they're very sensitive. They'll tell me that they react super strongly to things. They'll tell me that it may take them a long time to calm themselves down when they get upset.
Hmm.
Um, all sort of some of the hallmarks of BPD.
Yeah. And so you wouldn't see, so with someone with bipolar, then you wouldn't, would you say that if they do get upset by something that would normally upset someone, someone drives into the back of your car in traffic, but then they're able to calm down once they go, okay, well, we've just got to get this car towed now. That is something that that's how you would expect someone with bipolar to react. I mean, obviously, if they're in the middle of a manic episode, that's different, but is that
Yeah,
sort of
they'd be able to
a
regulate
difference?
themselves much better. Yeah, I
Yeah.
mean, they'll tell you, when I'm not manic, I'm not depressed, I can function fairly normally.
Yeah. Okay. And we've got a question in the chat about how do the traits of narcissism and BPD overlap, and in what ways can they be distinguished?
Well, they overlap significantly.
Yeah.
Uh, but I would say that in general, and then again, this is simplification, um, borderline patients report symptoms that are more related to attachment and relationships. Narcissistic patients, the problems have more to do with self-esteem and trying to preserve some sense of themselves as being important or grandiose, if you will. Um, Narcissism is a very, NPD is a very, for me, it's often hard to get my hands around what exactly it is, in the sense that it can present in so many different ways. They're the vulnerable
Mm.
narcissists, they're the aggressive narcissists, they're people who are covert narcissists. Uh, you know, and I mean, there's some people for whom it's just obvious that they're very narcissistic, usually more aggressive types. Um, but there's some people who are very narcissistic who are really high functioning, some who are very low functioning. Um, but I would say that, just to contradict myself now, one of the problems with BPD is it does involve identity diffusion. And I think that borderline patients often do struggle with really bad self-esteem. I would argue that they may spend time getting people to try to like them, take care of them, not abandon them. They're less likely to spend time trying to get people to act in ways that just enhance some sense of themselves that's grandiose.
Mhm.
Uh, and again, the distinction can be very fine, but there's a lot of comorbidity, but there's also a lot of comorbidity between BPD and all the DSM-5 personality disorders: obsessive compulsive personality disorder, avoidant personality disorder, dependent personality disorder, antisocial personalities.
Yeah.
Um,
Yeah. And also, I think, if you're very preoccupied with your own pain, which you can appear to be very narcissistic because selfish. You're not
Right.
attending to the needs of other people because if I've dropped a brick on your foot, you're not going to be concerned about the paper cut on my finger.
Yeah. I mean, in my experience, the people who are narcissistic, even if they're also borderline, are spending a lot of time doing things which are self-enhancing. I've certainly met a lot of borderline patients who are not, that they're much more interested in having some stable supportive object around them than they are in enhancing themselves.
Mm-hmm. Okay, that's an interesting differential. Thank you. Again, this is a whole webinar in itself, but what's the most effective treatment for BPD? Do they need to be stable to respond to therapy? As in not
Yes,
depressed or
this
suffering
is a
from
talk in
anxiety?
itself, but I will say that there's no one treatment which has shown itself to be the most effective for BPD. And I would argue that good supportive psychotherapy that focuses on skills and enlists the patient's supports in their environment in the process is going to be as good as anything. I've seen some borderline patients who, got better with a combination of sort of group therapy and then maybe some sort of supportive therapy, which wasn't even that intense. And that they got better to the same degree as someone who was in intensive, say, mentalization-based therapy or transference-focused psychotherapy, twice a week for a longer period of time.
Yeah, it's my experience is that psychotherapy does, skills-based therapy really does seem to help, even if that's
And there's this form of therapy called general psychiatric management, which is now getting disseminated more widely, which I think that's as good as anything, and it's much less expensive than the other treatments.
Yeah. So just a one-sentence definition of general psychiatric management for people that haven't heard of it. It's one that looks at life functioning. It looks at work. It looks at where you live. It says, let's have a look at everything around you, before getting into deeper therapy. Now we've got lots of questions about marijuana, medical marijuana, pot, weed, people, self-medicating with it. Is it destructive? Is it good? What's your clinical opinion, I guess, of medical marijuana to start with?
Well, I would say that heavy use of marijuana is not good for borderline patients. I think it really dysregulates one's mood, even though it may seem like it's regulating mood. I think it dysregulates it. I think it causes cognitive problems. I worked in a residential program where a very high percentage of the patients came in and they were using marijuana all the time. And the first month of treatment was complicated by the fact that they were withdrawing from marijuana. So I would say in general, less use of substances is better than more for borderline patients. They're, really, I think skills are much better than any substance for learning how to regulate one's mood.
Yeah. So you'd say that even of medical marijuana as well?
Well, I mean, it depends what you mean by medical marijuana. Here in the States, it's hard to differentiate the two. I mean, if people are using, I guess, small quantities, I suppose, but I mean, it really, it's the frequency of use, not whether it's medical or not. And I have no doubt that there are large numbers of people out there using marijuana to regulate their mood. And I've seen some individuals, not patients, who probably did function better using a lot of marijuana. It seemed to focus them. It seemed to help them feel calmer and so forth. But those people were the exceptions. More often than not, I found it to be an impediment to people getting better.
Yeah. Yes. I agree with that. I've not seen anyone do well using marijuana at all.
Yeah, certainly not heavy use.
Mm-hmm. Okay, I think there is, those are most of the questions that have sort of come up. and yeah, that I think that weren't the other questions that we were sent in were covered in your talk. So no, whoops, we've got one more message here. Let's just see a last question. No, we're getting into the thanks. So yeah, look, that was really fascinating for me. I think it really, because I see lots of people that have in a group context have been diagnosed with both or had diagnoses shift from one to the other, and you sort of have a general opinion about that, and it's really interesting to hear what the latest research and your long experience in this area has been.
Let me just make a general comment about psychiatric diagnosis. The sickest patients usually have multiple psychiatric diagnoses, and you can't say they're just one or the other. And it may be that the controlling diagnosis varies from hour to hour, day to day. So, one day you may be seeing something that's more bipolar. The next day you may be seeing something that's more borderline. So the challenge is figuring out what is contributing to this person's clinical presentation at the moment and how do you address it. And focusing on symptom complexes. Is it emotional instability? Is it interpersonal sensitivity? Is it anxiety? Is it sleep disturbance? And figuring out what you're going to deal with in the moment, which can be really challenging. But I don't spend a lot of time arguing with people about diagnosis in sicker patients because I've seen too many lengthy discussions of whether this person's really borderline or whether they really have depression or whatever, when it turned out they had all the above.
Yeah, and that's that the importance of patient-led recovery as well,
Right.
isn't it? That what does the patient want to work on?
Yeah. And so, a lot of clinicians, the more sophisticated ones, really take a dimensional approach as opposed to a categorical approach. I think a categorical approach where you say, is this someone is borderline or bipolar or whatever, is useful for sort of putting you into a general ballpark. But then you need to get much more granular and figure out what the problem is.
That's great. No, yeah, and just again, because we've got a really broad audience that watch these ones. Dimensional is just talking about how the severity along the scale, isn't it? It's sort of saying like you can be an emotionally sensitive person and life's going really well and your sensitivity's here, but then as life gets more difficult, your sensitivity might be out here and your reactions therefore will be bigger and your problems are going to be bigger. Is that a fair
I
summary,
would
or
say,
is it more?
I would amplify that a little bit and say, a dimensional approach might say, let's look at 5 different dimensions of what a person is like. Let's look at their emotions. Let's look at their behavior. Let's look at the kind of thoughts they have. Let's look at how impulsive they are. Something like that. And then within each of those dimensions, say, well, this person doesn't really have a problem here, but they have a more severe problem in another dimension. So it's not just saying this person is one diagnosis or another. It's just looking at, again, different strands and then trying to figure out to what extent a person's problem is relevant to that strand and how severe it is. Does that make sense?
Yeah, that makes a lot of sense. That really helps. And again, and that's going to be patient-led, isn't it? It's going to be, work's going fine, but my relationships.
Yeah,
Yeah,
exactly. I have problems at home, but work is good.
yeah,
Uh,
yeah.
so
Look, there's lots of thanks in the talk, in the chat. I would encourage you to have a look at that. But yeah, thank you so much. That was really was interesting, and to have someone who's had such a long experience in the area, and with many hundreds of clients you must have worked with, and their families, I'm sure, are appreciative of the work that you do. And thanks for sharing that expertise and
sure.
experience
Well,
with us.
glad to do it, and I encourage people to get educated as much as possible because BPD it's a difficult but treatable problem, and the more you know about it, the more effective you're going to be.
Yeah. And I think
And
that's the
yeah,
great takeaway. It's a difficult but treatable problem.
yeah, and get plenty of support from the people around you
Yeah.
in dealing
Yeah.
with it. So,
Now that's great. No, thank you so very, very much. I am going to stop the recording now.
all right. Well, nice seeing you. Glad to come back some other time if you want me to talk on another matter,
Oh, definitely. I'm
another
definitely
topic.
going to, and I'd love to. There are professional networks in Australia that, um, uh, that I think it would be wonderful for you to talk to them too, because I still feel that there's, it's one thing for families and people with the conditions to educate themselves, but there's still across the health spectrum of professionals, there's such a levels of knowledge around this topic that vary so much and can
Sure.
have such an impact on people's experience.
All right. Well, I'm going to sign off.
All right, thanks very much.
Sure. Bye.